Hello, sir.
Hi. Hello, Vinay sir.
We'll wait for 2-3 minutes, sir. We'll just start, sir. So, welcome everyone. Thank you for joining. So, as a part of Fungal Disease Awareness Week from 18th to 22nd, we are having this webinar, Fungal Infections 101. So, on 18th, we had the first session. So, today's session, we have good talks and cases lined up. So today we have Dr. Vinay Kumar Hallur. Sir is additional professor and in charge, and sir will be talking on what is known. And today's sessions are moderated by Dr. Deepak Kumar. And then we have interesting cases in fungal infections by various ID fellows. So let me introduce to your moderator. So Deepak Kumar sir is associate professor in Division of ID in Department of Medicine, AIIMS Jodhpur. Sir has multiple publications, received outreach grant for oral presentation, and has involved in various intramural and extramural projects, and with more than 14 paper and oral presentation. Sir is the coordinator of infectious disease, DM infectious diseases here in AIIMS Jodhpur. So over to you, sir.
Good evening, all, and thank you very much, Akshatha, to invited me as a moderator. And I think it's a very good initiative to learn or increase awareness about the fungal diseases because it's growing concern nowadays, especially after the COVID. So, in this series, the first talk will be given by Dr. Vinay Kumar Holar sir and Akshatha to show the PPT. And sir is working as the
Yes.
additional professor at AIIMS Bhubaneswar, and the area of interest of sir is clinical microbiology, mycology and H. pylori. And sir has discovered an new fungus is Cunningamela arunaloke. And for that, he also got a grant from DST to present this in International Mycology Conference in 2019. Along with this, sir also developed and evaluated the rapid test for mucormycosis. That is very, very important and it's a need of the time. And he has stabilized the ICMR Mycology Reference Center at AIIMS Bhubaneswar and had more than 15 publications. And sir is going to talk about pneumocystis. Over to you, sir.
Thank you, Dr. Deepak, and thanks, Akshata, for calling me to give this presentation. I got to know about the fact that you're going to present your topics that you take here as a part of ECMID, if I'm right? Empowering microbiologists to be ID physicians in the absence of ID physicians, if I'm right.
Yes, sir. Yes, sir.
So great going, Akshata. Very proud of you. And with that, I'll want to start my talk. So I'll be just sharing my screen. Just let me know if I'm visible and
Akshata,
audible.
stop sharing.
Yes, sir.
Yeah.
Please share, sir.
Yes.
Please share, sir.
So before starting sharing, I just want to say that I will deliberately be speaking very slowly. This is because I want people to understand, and I also want people to know that if they have any queries, they can stop me then and there. But since this is a webinar platform, I guess we'll wait till the end of the session. Please write down your queries, and I'll try to answer those queries at the end of the session. So let's start. So are my slides visible?
Yes, sir.
Yes, sir.
Yes, sir.
Yeah, so this is the question to all the people who are attending this this webinar. Does anybody know who this lady is? I mean, you can just unmute yourself and help me out, or let me know who is this lady. So I'll just wait for another 30 seconds. You can even use Google Lens and reverse search this if you want and find out who she is. Any volunteers? I think we might be, no idea. Okay.
No idea, sir.
No idea. Okay.
Any hint, sir? People are asking for some hint.
She's somebody who has something to do with Pneumocystis carini or Pneumocystis cerevisiae. How to Google? No hint. Okay, so let me.
Sandy Ford.
Yes, this is Sandy Ford, and who was this? Who said that?
I am Dr. Sheetal.
Dr. Sheetal, can you just elaborate more about Sandy Ford?
during the first HIV epidemic, I mean, when they first identified this, in a series of patients of having pneumonia, they isolated PCP in them.
Okay, so the story goes that Sandy Ford is a clerk. She's a drug technician at CDC. Okay, she's not even a doctor. She's a clerical staff who is posted at CDC and who is in charge of handing out orphan drugs. You know, orphan drugs are drugs which no company manufactures because they don't have commercial value. One such drug is pentamidine. If you can see in her hands, she is holding. Can you see this? I think the font is even clear here. It is pentamidine what is it? Isethionate. Okay. So Sandy Ford noticed that suddenly during 1981, suddenly there was increased demand for pentamidine, and this demand was coming from the New York area. And when she talked to one of those physicians who was ordering it, she found that all these people were males, they were homosexuals, and all of them presented with pneumonia. She told this to her boss, which led to the discovery of the HIV and pneumocystis epidemic. This was how the pandemic of HIV was it entirely started because of one lady who did her job rightly. So moral of the story is you don't have to be Superman, you don't have to be a physician, you don't have to be a soldier. If you're doing your job right, if you're observant, you will still be recognized by mankind. And she is recognized as the herald of HIV epidemic. So everybody knows who Sandy Ford is now. Great woman and a great contributor to microbiology, despite her not being a microbiologist, not being an ID physician, and nowhere related to medicine. Okay, so this is her story. She brought it to the notice of her boss that there was a sudden surge in demand for pentamidine, which was investigated, and this came as a report in MMWR, and she is known as the herald of HIV, and pentamidine was being given for treating pneumocystis pneumonia, right? So this is about Sandy Ford, who recently died in 2016. Okay, so this brings me to our topic, what is known in pneumocystis. And the questions that I'll try to answer in this webinar are as to what causes it, okay, and what is its transmission cycle, what are the disease trends, how does it present, are there any differences in presentation in different groups, and what's the best way to diagnose it. Okay, so moving further. So what causes it? You know, when the agents that cause it's a bumpy ride whenever you read about history of pneumocystis carinii /0 VC. You know, when you go back almost 100 years back, it was in 1909 that Carlos Chaga found these organisms in experimental animals and thought that they were a part of the life cycle of Trypanosoma cruzi, and he just left it at that spot. But there was his contemporary who was Carini, who was just one city across in Brazil, who found them in rats. And this fellow was intrigued, and he sent these samples of the dead rats to the Delanoy couple. You know, the Delanoy couple were husband and wife, both who were microbiologists who were working in the Institute of Paris. Now, a Delanoy couple, they found this life cycle, these stages, not only in the samples that Carini sent from Brazil, but they also found them in the Parisian rats. And this prompted them to identify it as a separate new species and they named it as Pneumocystis carinii in honor of Carini, who sent the samples. And subsequently, after this, there was not much mention of it except for a few reports of it causing interstitial pneumonia in children who were malnourished in orphanages during World War II. And then suddenly Sandy described, and she was the herald of the AIDS epidemic by discussing those 5 cases of pneumocystis pneumonia in 5 gay men at New York City. So from there till 1988, from 1980 to 1988, till this time, it was always considered as a parasite. Subsequently, the molecular methods they made it possible to be identified it as a fungus. But then why was there this confusion always whether this was a parasite or a fungus? The reason was that ultrastructurally it had some structures like pellicle, which made people think that it was a parasite. Moreover, it had a single 16S rRNA. It never had it does not have ergosterol in its cell wall, did not respond to amphotericin B, but did respond to trimethoprim sulfamethoxazole, which, other than being an antibacterial drug, is also an antiparasitic drug. So these were the things in favor, and that's why it was being thought as a parasite than a fungus. But then when they went ahead and did the molecular studies, what they found was it was a fungus than a parasite. And subsequently, then they again looked into the molecular study. And what they found was when they took all the pneumocystis sequences and they aligned and made a family tree, or what is called in scientific terminology the phylogenetic tree, they found that each species or each group of animal had its own species of pneumocystis. And you can see this is where pneumocystis 0VC that infects humans. This is where pneumocystis is 0VC is, and this is where pneumocystis carinii is. So pneumocystis carinii was closer to pneumocystis murina, and these two pneumocysti were causing infection in rodents. And then there were other pneumocystis which grouped across the animals or the major group of animals that they infected. So much so that it is now said that if you wish to discover a new fungus, you start working on pneumocystis and you start working on the animal. The pneumocystis that you will discover will be a new species, and you can name it according to your whims and fantasies. So this is the level of specialization that pneumocystis have. That is, a pneumocystis that infects rodents will not infect pneumocystis that humans or primates. So previously, the concept that pneumocystis was a zoonosis has been debunked now. Pneumocystis 0VC is the pneumocystis that infects human beings, and it is not pneumocystis murina or pneumocystis carinii. And from there, there have been around 8 pneumocystis that have been properly named as per the International Botanical Nomenclature System. The rest are all named SOS by the investigators, and they have not yet been ratified by the botanical group. Right. So this pneumocystis is a fungus, but because it was thought to be a parasite in past, its life cycle was divided into 3 phases. That is the trophozoite phase, which is the active feeding phase. Remember that this is the phase that multiplies asexually, and the cyst phase, which is formed after 2 different sexes mate. Okay, and remember that the cyst form is the one that is infective to humans. Okay, so there are 3 stages in the life cycle of pneumocystis, that is trophozoite, precyst, and cyst. Trophozoite is the asexually reproducing form which is responsible for the disease. Cyst is the form that is generated after sexual reproduction and is the infective stage. Right. So who gets infected? Susceptible patients get infected. So you might be knowing that HIV was, pneumocystis was one of the AIDS defining illnesses in past. Subsequently, in the next slide, you will come to know that it can infect anyone with immunodeficiency. And the most recent addition to the list of risk factors for pneumocystis is COVID-19. COVID-19 has also been added to the list of risk factors for development of pneumocystis pneumonia. So how does a person, a susceptible host, get infected? A susceptible host gets infected when he inhales the cysts. And where do these cysts reside? These cysts reside in pneumocystis carinii patients with pneumonia. They can also reside in healthy infants, and they can also stay in immunocompetent or immunocompromised individuals where they act as colonizers. So a susceptible host, when he is exposed to a patient who is colonized or a patient with disease, can develop pneumocystis pneumonia in case his immunity is less. So what's the portal of exit? The portal of exit is the respiratory tract. The portal of entry is again the respiratory tract. So how do you prevent it? By taking respiratory precautions, you can prevent the transmission. So the route of transmission is airborne transmission. Right. So I told you the new group that was added to the list of people who are susceptible to pneumocystis was coronavirus. And since 2020, there have been more than around 70 reports of pneumocystis across the world. And you can see the maximum number of reports are from Europe. And we also have these reports from India as well. So the reports, the pneumocystis can also cause pneumonia in patients who have had SARS-CoV-2 infection. So remember this. So this is one takeaway from this webinar. So what were the trends? So you know that pneumocystis was a AIDS defining illness, and subsequently there was use of HAART, that is highly active antiretroviral therapy. So HAART was introduced almost during 1995 in the United States of America, and post HAART implementation, you can see that the trends of pneumocystis pneumonia have declined, as have the trends of other opportunistic infections in HIV. So the trends of pneumocystis pneumonia, which declined in USA, have also declined in other places where the HAART therapy has been instituted, in other parts of the world where the HAART has been instituted for treatment of patients with HIV/AIDS. Right. So how is the data in non-HIV patients? So this is data. This is the trend of infection pneumocystis pneumonia in England, where you can see that this is the graph, or this is the line that shows the data of patients, hospitalized patients with pneumocystis pneumonia, and these are the patients who do not have HIV. So during the early 2000s, the trend, there was a downward trend, that is the pneumocystis infection was being detected earlier and being treated earlier, and patients were put on HAART. So the trends, there was a downward trend in the incidence of HIV associated pneumocystis pneumonia, while there was an increasing trend in England as well as in Germany. Okay, so this is the trend of pneumocystis pneumonia in HIV patients, while this is the trend in non-HIV patient, which brings us to the fact that there are two distinct populations of patients who can develop pneumocystis, that is patients with HIV and patients without HIV. So, having said that, this can basically cause infection in patients with low immunity. So can it cause outbreaks? Yes, it can also cause outbreaks, and it is mainly reported to cause outbreaks in patients who have received transplant. So majority of the cases have again been reported from the Europe, while some cases, I mean, a handful number of cases of outbreaks have also been reported from India. So proceeding further, what are the clinical features? The patient with pneumocystis presents with fever. He or she presents with cough, and then he or she presents with dyspnea. Subsequently, in such a patient who is predisposed to pneumocystis pneumonia, when you do a X-ray or you do a CT is better than X-ray. What you find is you find ground glass opacities which are perihilar in location, and then there are several other things that are described in the radiology. I am not a radiologist, I am not an ID physician, so I will not get into the details of this. But having said that, I told you there are two set of patients, one HIV positive and other non-HIV patients. So both of them can develop pneumocystis pneumonia. So is there a difference in presentation? Yes, there is a difference in presentation. In that, pneumocystis infection reveals HIV status in patients who are HIV positive. That is, it is a AIDS defining illness. In somebody who has pneumocystis pneumonia, there are higher chances of him being HIV positive. But it does not reveal the status of transplant or transplant rejection in non-HIV patients. The onset is relatively slower. Patients with HIV tend to present with a gradual onset cough, fever, and dyspnea compared to patients without HIV who present with a rapid onset pneumocystis pneumonia. Again, the illness is relatively milder in patients with HIV compared to patients without HIV. Hypoxemia is less frequent in patients with HIV compared to those without HIV. And again, almost 50%, up to 50% of patients without HIV will die when they develop pneumocystis pneumonia. And this is because of many factors. One factor being the delay in diagnosis, because the physicians don't think of it as a differential. It is usually thought of it at a later stages compared to those who present with these cough, fever, dyspnea in HIV. A patient with a transplant or a patient with immunosuppression due to XYZ reason, in them other reasons are thought of than pneumocystis, which contributes to the mortality. LDH, which has very good sensitivity and specificity in HIV, has a very low value in patients without HIV, and its level are high only in patients with HIV compared to moderate increase in levels in non-HIV patients. Again, when you do a ball fluid microscopy for identifying this infection, you get a very low cyst number in non-HIV patients and a robust immune response consisting of many neutrophils compared to a more number of cysts and less neutrophils in HIV positive individuals. Am I clear till this stage now? Are there any doubts till now?
There are no questions in the chat box yet.
Okay, so I'll proceed further. So how do you diagnose pneumocystis? So any guesses? What is the gold standard for diagnosis of pneumocystis pneumonia?
Bal James are staining, GMS staining. They are putting in the chat box.
Or IFA. Yeah. So what my question was, what is the sample? What's the best sample for diagnosis of pneumocystis pneumonia? So we have people who said lung biopsy, and we also have people who said BAL and induced sputum. So you know, the gold standard is definitely What do you say? What do you feel? It should be biopsy or it should be BAL? Do we have a polling option here? We don't have a polling option here, right? Okay, so my answer to this question is because it's a fungus, the gold standard is always going to be a biopsy, right? So it's a fungus, the gold standard is always going to be a biopsy. So the gold standard is indeed an open lung biopsy, and it makes more sense in non-HIV patients compared to HIV patients. But then because you are not able to do a lung biopsy, I mean, just for the sake of diagnosis, if you go for an open lung biopsy, then definitely the patient is not going to come back to you, right? So the alternatives to it or the proxy to an open lung biopsy is a bronchoalveolar lavage fluid. And in the absence of bronchoalveolar lavage fluid, people have used induced sputum, they've used spontaneous sputum, they've used nasopharyngeal aspirate and oral washes. Now, the point that you need to remember is the sensitivity of the tests and the fungal burden, it goes on reducing as you come from the lower respiratory tract to the upper respiratory tract. So, the burden as well as the sensitivity reduces as you go from open lung biopsy to BAL to induced sputum to spontaneous sputum to nasopharyngeal aspirates to oral washes, right? So this you need to remember. So how do you can you culture it? Is culturable?
No.
So it is not easily culturable. Though it is cultivable, it is not easily cultivable. You cannot cultivate it for the sake of diagnosis. And the systems that are available for culturing are pretty expensive and they also need a lot of expertise, right? So then how do you diagnose it? How do you diagnose it is by looking at it, and you look at it by doing microscopy, by either doing a conventional microscopy or by doing fluorescent microscopy, or you have biomarkers, and finally you can have PCR. And there are different formats of PCR, that is nested PCR and real-time PCR. So when you have a lung biopsy, the first thing that anyone does when somebody biopsies anything, the surgeon only remembers pathology. So it comes to pathology, and the first stain that is done whenever the surgeon sends the biopsy to the pathology department is the H&E stain. So what is visible on H&E is foamy exudates. Okay, foamy exudates are visible, but H&E does not stain Pneumocystis carinii, right? So you need other stains to stain Pneumocystis carinii. And what are the other stains? People had answered in the chat box. Okay, so people had answered in chat box. Any other? I mean, do you want to tell again? So the other stains that are used are you have Gomori methanamine silver, which is the commonest stain in microbiology. The problem with Gomori methanamine silver is that it is time consuming, right? And then you have Ginza, wherein the organism shows a red purple nucleus and clear zone around it. So this is how a cyst looks like. Okay. And then finally, that is the one that is rapid, and the one that is sensitive, and the one that is expensive, and the one that is not available in majority of places, that is immunofluorescence, right? So how do we go ahead and how do we diagnose the infection using these techniques when there is a low burden in patients with non-HIV? Okay, so this becomes a problem in patients who do not have HIV and who have a very low burden. So in this group of patients, because the burden is less, microscopy can be sometimes problematic if it is used as the only method for diagnosing Pneumocystis zerovc. So we should have certain alternatives and we should have the other ways for diagnosing. Having said that, I told you it has 3 stages. What you need to remember is not all stages are visible on microscopy. This makes more sense because the only microscopic method where you'll find both the trophic stage and the cyst form is the direct immunofluorescence. Okay. In the rest of the methods, say in GIMSA, not in GIMSA, in Gomery's methenamine silver, trophic stage is not found. What you find is only the cyst stage. That is the ones that are described like ping pong appearance, resin appearance, hat-like appearance. All these are asci and they are not trophic stages. Similarly, you cannot identify the trophic stage using chalcofluor white. So in chalcofluor white, you will find only the honeycombed apple green fluorescence of trophozoites, while in GIMSA, you will not find the asci. Okay. But does it have any bearing on the disease process? Does it have any bearing on the disease process? Anyone? The microscopic stage, the detection of microscopic form, does it have any bearing on the diagnostic performance and the disease process? Is my question clear?
Yes, question.
Okay, the question is clear, but because there are no volunteers, let me answer. It has absolutely no bearing on the disease process, no bearing on the prognosis, and no bearing on the diagnosis. Okay, so in JMS, if you find asci, you will still diagnose pneumocystis pneumonia. In IF, if you find either of this, you will still diagnose. Okay, but remember, look at a report with suspicion if somebody has reported trophozoites in an indirect IF. Okay, go back and speak to the microbiologist or the pathologist if they describe cysts in GIMSA, if they describe trophozoites on chalcofluor white. Please discuss with your pathologist if they are doing this. Okay, because these life stages are not seen in certain type of staining techniques. Okay, so what is the alternative? I told the alternative is PCR. PCR has used many targets. The ones that are most commonly used is the mitochondrial LSU, which is also used for genotyping. They also use the dihydroteroate synthase enzyme, which can also detect resistance to the cotrimoxazole, that is trimethoprim sulfamethoxazole combination. And you also have, there are papers that have also used MSG and beta tubulin. Now the advantages of PCR are that it is objective, it is sensitive, it is specific, and it has a very high negative predictive value. But a positive test does not correspond with infection. Remember this, a positive PCR for pneumocystis carinii does not mean that the patient is infected. And it is always recommended to use real-time PCR than nested or conventional PCR. And a low CT or CQ value favors pneumocystis carinii infection compared to pneumocystis colonization, which is usually found in high CT values. Having said that, is there a cutoff? There is no cutoff across the world, right? So how do we interpret it? We interpret it in conjunction with other tests, that is beta-D-glucan. Beta-D-glucan has been used as a screening tool. A negative test rules out pneumocystis in patients with low pretest probability. And if you have a positive beta-D-glucan, you should always consider other invasive fungal infections because beta-D-glucan is a pan-fungal marker. Beta-D-glucan is a pan-fungal marker. And remember that beta-D-glucan, falling levels of beta-D-glucan does not mean that the patient is getting better from pneumocystis pneumonia, right? And Till date, there are no studies that have assessed its utility in pneumocystis prophylaxis, whether you should stop pneumocystis if the beta D glucan level fall. We don't have such studies, right? So how do you diagnose it? Okay, so the first thing that you answer when you have a patient with cough, fever, dyspnea, and X-ray findings indicative of pneumocystis is you see whether you can do a BAL or not. And if you can do a BAL, go ahead and do PCR and immunofluorescence. So if both are negative, the patient does not have pneumocystis pneumonia. If both are positive, the patient has pneumocystis pneumonia. If qPCR is positive, but IF is negative, then the patient may have colonization. Okay, but remember, if the IF is negative, but the CT value is low, the CT value is low, which means the levels are high, then don't diagnose it only with the PCR value. Also look at other marker. The patient had a moderate to high pre-test probability. He has high loads and his beta D glucan levels are also increased. Then again in this scenario, the probability that the patient has pneumocystis pneumonia is increased. Okay. Finally, if your PCR is negative, but your immunofluorescence is positive, then the probability is that this is a false positive IF test. Okay. So I told you, you had a patient in whom you could not do BAL. What do? BAL is not possible. You do a beta D glucan. And if beta D glucan is negative, pneumocystis 0VC is ruled out, which means beta D glucan has a very high negative predictive value in patients with low to moderate probability of low to moderate pretest probability. A beta D glucan, if it is negative, can rule out pneumocystis pneumonia. But if it is positive, then it could be pneumocystis pneumonia or any other invasive fungal infection. So in this patient, if you had a beta D glucan and you also had an induced sputum and again you did qPCR and both turned out negative, qPCR and IF, again you ruled out pneumocystis 0VC, and if both were positive, again you have ruled in pneumocystis 0VC. If qPCR was positive only, you add a serum beta D glucan, you look at serum beta D glucan, and you also look at the CT value to interpret your values. Again, if qPCR was negative, but your IF was positive, then this is a false positive test. So summarizing, this is the ESL guidelines for non-HIV patients. So summarizing, in a patient with clinical suspicion of PCP in a non-HIV patient, you do a BAL. If BAL is not possible, you do a beta D glucan. If your beta D glucan is negative, your pneumocystis is ruled out. If it's positive, it can be pneumocystis or other invasive fungal infection. And in that group of patients, you do an induced sputum. And in those patients, if you have a qPCR and IF, both of which are positive, then it is pneumocystis 0VC. But if in this group of patient, if your PCR is negative and your immunofluorescence is negative, your pneumocystis can still not be ruled out. Okay. So if your qPCR is positive, but your immunofluorescence is negative, and the patient is in moderate to high risk of infection, you will look at the CT value, you look at the beta D glucan levels. If your qPCR is negative, but your IF is positive, it means that the test is false positive. And in the BAL, it's the same, right? So it is the same. Is it clear till now? Are there any doubts here? Are there any doubts or queries? So if there are no queries, I proceed further. I go further, which brings me to to almost the end of my presentation. Was the treatment? I am not going to go into the details of treatment. You know that the treatment, the first drug of choice is trimethoprim sulfamethoxazole. The alternative drugs are pentamidine, primaquine, clindamycin, and dapsone, or trimethoprim and atovaquone. And these drugs have to be used by looking at the type of patient you have. If you have a transplant patient in whom any of these drugs are contraindicated, then you need to choose the alternative drugs. So I'm not going into the details of the therapy for it because that's not my specialty. So one thing that you should remember though is that the patient may deteriorate in the first 2 to 3 days despite adequate therapy, and it's a known phenomenon. Don't get worried if your patient is becoming worse in the first 2 to 3 days of therapy. It is a good sign actually. So you should think of revising your treatment option after 3 to 4 days of adequate therapy. If the patient is still not improving, then again revise your diagnosis, or if your diagnosis of PCP is short, revise your management protocol. So when do you do it? You do it after 4 to 8 days. And if there is no response after 4 to 8 days, it is deemed as treatment failure, right? So again, summarizing, you have patients with HIV and without HIV who can get infected, have the disease. The patients without HIV are those that have CD4 count, summarizing, CD4 count less than 200, who are on prolonged corticosteroids, on transplant, hematological malignancies, immunosuppressive conditions, and recently COVID-19. In HIV, again CD4 count less than 200, low CD4 count, absolute or percentage, oral candidiasis. In patients with HIV and oral candidiasis, they are at risk for development of HIV, or who are non-compliant to retroviral therapy. Now, this completes my session on pneumocystis. Having said that, I would want to talk for a few minutes about our center and the work that we are doing. We have been nominated as the reference center for eastern part of India. Having said that, we still receive requests from across India. We don't limit ourselves to only India. We have helped 116 people last year from across India, and while helping, what happened was we described the first few cases in the world. We had the first world's case of Acremonium fuscum causing keratitis, first world's case report of Arthrium russicka-ravindra and Neodyctonia subglobosa. We described the first report, Indian first report of Madurella faali from India, first reports of Fonseca nubica and Fonseca monophora causing chromoblastomycosis from India. Again, first report of Rethedicetron rufulum from Tamil Nadu, which is right now accepted for publication. So we are taking baby steps and helping people describe fungal infections or foci of fungal infection better. We are also conducting workshop. These are mainly in diagnostic mycology. Later, we also will be conducting clinical mycology workshops, and we are helping other organizations. We are helping students come and train here. PhD students, they are coming at a lab and they are doing their thesis. So if anyone is interested in doing anything related to mycology, any study, any unidentified isolate, please do remember us. If you need any help or educational material in mycology, we are here to help you. And this is our website, icmr.amdrc.bbsr.in. These are our phone numbers. Me and Dr. Diptanu, we are looking after this laboratory. And recently, we have added a lot of free resources in mycology on our website. You can visit our website, and you have a lot of free mycology resources which you can access through our website. Thank you. Thanks again, Akshatha. And if there are any queries, I think we can answer those.
Thank you so much, sir, for extensively covering pneumocystis. And most often we know that about pneumocystis in HIV. So it was like from the history till the treatment, you've taken us through the journey. It was very enlightening and very simple and very easy to understand, sir. For coming to the question, I think there's one question, sir, by Farah Hussain. How about additional echinocandin in severe PCP? And next question, where is the mode of action, cyst or the trophozoite, sir? Echinocandin.
This is a part, I mean, this is something that is going on right now. There was a meta-analysis probably in CMI or so. Now, echinocandins, they act on beta-D-glucan synthase, and beta-D-glucan is present only on the trophozoite. So you should not give it alone. If you want to give it, you give it as an add-on. So it should never be given as a monotherapy for treating pneumocystosis. So it is given as an add-on. And as I said, in patients with transplant in whom, you know, there are some contraindications for using those first, second line drugs. So in that group of patients, people are trying to use this echinocandins and they are working on it. I'm not sure if the guidelines are out and clear on this aspect.
Yes. Sir, like you were discussing about your lab, the diagnostic supports which you're going to provide. It will be of great help. Even I think from our center, we have been collaborating with you for identification. So pneumocystis PCR, sir, are you currently doing such? So if at all we are suspecting, can we send, and procedure, if you can explain, sir, I think I'm sure there will be many participants who will be interested to send the isolates for identification.
I hope you don't mind me standing because I'm having a little bit of that.
Yes, sir. Yes, sir.
You know, PCR, what PCR we do is we do real-time PCR and we do a commercial assay. And this we are doing because there are issues of comparability across centers. Okay, so one problem that happens is if you are not using a commercial assay, I mean, the adage, old adage, you should compare apples with apples. So the results of home brew PCR cannot be compared with a commercial PCR because the targets are going to be different. The way of extraction is going to be different and the way of detection is going to be different. Having said that, the cost of running the commercial PCR assay is pretty expensive. So because it's a kind of a quantitative assay, you have to batch it. Okay, you cannot do it SOS because you need to have calibrators running. It's something like beta-D-glucan assay, pretty expensive, and a positive has to be run again. You need to run calibrators. So it's not economically viable if you don't have more than 3 to 4 samples. And the size of the kit is 25 reactions only. The cost of the kit is I think around 28,000 rupees. And if you get 1 or 2 samples in a week, in around 3 weeks, your kit is over. So you know, we were doing the commercial assay, but because it was extremely expensive, we are now again shifting to home brew, and we have standardized the home brew PCR, and we have selected a cutoff of 25. And if the CT value is less than 25, we do discuss with our clinicians, and then you know, we give it as positive. So I think I told it in a very haphazard manner. So I'll just refresh what I said. So PCR, there are multiple formats. You have commercial assays, and then you have home brews. Okay, home brew are the ones that are standardized in the lab. Commercial are the ones that the company sells across the world. One company, I mean, I'm not endorsing it. This is a financial disclosure. I'm not endorsing it, but it is available across the world. It's the Pathognostics pneumogeneous assay, which is available which is a kind of a quantitative PCR. So this quantitative real-time PCR gives us the methodology, and if you follow that methodology, it is assumed that your results will be the same as a result if it's repeated anywhere in the world. Okay, because the methodology is going to be the same. So that is about the commercial assay that is available in India. One of it that is available is a pneumogeneous assay, and the pneumogeneous assay not only tells us about the load of the fungus, it also tells us about the presence or absence of resistance mutation. I was talking about DHPS, dihydroteroid synthase. There are certain hotspots. If there are mutations, then the PCR assay tells you that this mutation is present, and then you can call up the clinician and say, probably trimethoprim sulfamethoxazole is not a good combination. You should use something else in this patient. So that assay, the pneumogeneous, other than telling us whether the patient has pneumocystis carinii or not, it also tells us if the patient has an infection due to a resistant bug. Right. The rest of the homebrew assays, they either tell you if the patient is infected, or they tell you if the patient has a drug resistance mutation or not. Most of the times, the assays, the homebrew assays, they only inform you of the fact that there is infection or colonization, and that too, it has to be correlated with the clinical condition and the serum beta D glucan levels. Was I clear, or I need to repeat it again? Having said that, all homebrew assays, majority of the people across the world have shifted to the real-time PCR format because it is more sensitive and more user-friendly compared to the older studies where they use a nested PCR format. Right. Having said that, many academic organizations still use the nested format and tell whether the DNA is present or absent. They don't tell the cutoffs. Okay. So you can have cutoffs by way of CT value, or you can have absolute number. There are some kits, some of the PCRs have been standardized to give absolute numbers as well. So the problem is there is no consensus on a threshold because we don't have a standard. Why we don't have a standard is the same reason why we did not have a standard for COVID PCR. Because when you take a respiratory sample, you cannot standardize the initial inoculum. Okay, you don't know. When you take blood, you know that you are taking 2 ml blood. And 2 ml blood is going to give this ml plasma. And when you extract DNA from this amount of plasma, this level is going to correlate. But when you put a swab or when you put a ball, you're not sure whether it's the same distribution of pathogens in a swab or a ball. I hope I'm clear.
Yes, sir.
That's why we still don't have consensus thresholds.
Yes, sir. So, I think once one of them was asking, what is the procedure to send the unidentified isolate to you, sir? Maybe you can leave your email ID or and the website links for the help.
Yeah, the answer to that question is that you send us the actively growing isolate. We'll try to identify it. If phenotypically it is possible, we'll identify it. If it's not possible phenotypically, then we'll sequence it and let you know what's the bug. I'll post you my email address and the website details, and you can directly contact me with how it is to be done.
Yes, sir. So even on YouTube, I'm just checking, sir. There are around 50 participants, and yeah, they are all appreciating, sir, your talk. It was very good, sir. Thank you again for providing the various insights about pneumocystosis, sir.
I deliberately did not want to add a lot of data and a lot of mumbo jumbo because when I was a resident, it was actually difficult for me to make out the ins and outs of the data. So I tried to make it as simple as possible. But if somebody is actually interested in knowing the data and the data sets, they can again contact me and we can have a discussion regarding the available data on the diagnosis of pneumocystis.
Yes, thank you so much, sir. And again, I would like to extend my heartful gratitude for accepting it on a such short notice. Yes, sir. And sir, will be available if at all any questions you can ask sir, and the email ID will be posted, so you can, for any other further queries, you can contact sir. Thank you again, sir.
Yeah. So.
Good evening to all. I'm going to present my interesting case, Beyond the Darkness. I will go with my case timeline. 65-year-old male, farmer by occupation. He came from Rajasthan. He is known smoker and alcoholic for a long time. He had multiple problems. From 2000, he had a history of arthritis, multiple large joint pain, more than small joint pain. And he treated both allopathic and Ayurvedic treatment. Initially, he thought osteomyelitis and he taken Ayurvedic treatment or OTC, over the counter, some pharmacy, he received some steroid and others. After that, he taken not improved. Then he went for evaluation for physician. They diagnosed rheumatoid arthritis and then they treated. But again, the symptoms are not improved. Again, he went for Ayurvedic treatment and he had not much benefits from medicines, and he had history of 2015 had septic arthritis on right knee, and then it was not improved by medications, and then he went for arthrostomy and then diagnosed as MSSA bacteremia at that time, and he treated adequately. After that, he had 1 year back, he had some viral illness, dengue fever, in thrombocytopenia, which was improved by supportive management. After that, after that, he had some complaints, like the way he had right knee below right shin, he had swelling, and same hand up. After that, he had left right knee swellings and followed by right elbow. Below the right elbow, he had some olicron. Below the olicron, he had swelling on the elbow, which was globular swelling. Initially single, followed by multiple, like 3 to 4. It's not connected. It is movable. As per history, he is telling like that. It's freely movable. It's not attached to bony. He had 2-3 episodes of spontaneous rupture, followed by he had pus discharge. Pus discharge, which was chocolate corpus, is infective, like the way. On and off, he had some itching on the same side, followed by he had now came with signs of inflammation changes, redness and warmth he had, like the way himself he explained well, followed by he had left knee swellings for 1.5 years. Previously, right knee septic arthritis, now left knee swellings for 1 year. It's diffuse, not localized any place, even bony. He had walkable, it's not disturbing any day-to-day activity. And another complaints, main complaints, he had itchy forearm and body he had for 3 months. Because of maybe he taking over the counter and ATC over the counter and Ayurvedic treatment, it was not explained himself. He had diffuse itchy rash, which was no daytime or nighttime any diurnal specific that was. Examination wise, patient had Cushing-eyed face and because of steroid abuse. Another thing he had edematous, which was pitting, and dystrophied nail he had, like the way you see dystrophied nail, like the way he had. Another thing, this is Cushing-eyed faces because of steroid overuse. Another here you see clearly destroyed nail. This is he had some swelling and some aspiration he had 2-3 times in outside in left knee. There is marking here. Here right knee, see clearly there is osteotomy because of septic arteries he had. Left knee he had, there is 1, 2, 3, 4 swellings, which was globuloid swellings. It's freely movable, not connected to anyone. It's not attached to the bone. There is signs of inflammation like the way warmth and tenderness mild he had. That is right when I went to there, right below the elbow he had, there is INT that was done. That's why I don't have picture that time. Another thing, see because of itching, he had forearm and back and abdomen everywhere. He had some scaly erythematous lesions over the trunk and abdomen everywhere. He had even limbs. We went for basic investigation. CBC everything normal, but urea creatinine there is altered, and albuminuria also he had. Because of steroid abuse, he have cortisol level is very low. There is yearly morning sample, and the CRP is more than 40, very high. Even rheumatoid factor is very high. We went for ultrasound. Ultrasound shows altered renal echoes. It was not normal in size. It's whether AKA or CKD, it was not mentioned clearly. Then we went for that first aspiration. That time there is the first was lymphomononuclear cells, only mild cellular lymphomononuclear with RBC. There is no evidence of any tumor or malignancy. Ultrasound, the ultrasound shows he had multiple subtypes.
Of course he is. I feel it. And you do too. When you tell the story, you're bearing witness.
As for ultrasound shows, same thing they mentioned, like freely movable lesions, subcutaneous and all, globuloid cystic swelling. At present, we have doubt. 3 months, he has 2 years history of swelling and all. There is where will fit. There is diagnosis and differential diagnosis, what will go like the way. The time we diagnose right NTM, nocardia, TB, even some kind of fungal and chronic battery infection because of he had already MSSA battery on right knee. Now maybe skin infection also here. Another thing, non-infectious causes also possible. That's why we need to rule out this kind of patients. We go through the guideline. There is ulcerative skin lesions and nodular lesions whether had. First, we need to check for immune status. Patient have immunely suppressed or non-immune suppressed. If immunely suppressed, we need to check for whether limb alone involved, extremities alone involved, or abdomen thoracic involved. If abdomen thoracic everything involved, we'll go for galactomannan and endemic mycosis we need to rule out. If no systemic illness, we need to check, aspirate the fluid. We'll check for neutrophilic predominant or lymphomononuclear predominant. Neutrophilic predominant, that one is bacterial causes most probably, intracellular bacteria most probably possible. If lymphomononuclear is very high, then we need to think for fungus or TB, NTM, that thing we need to think. If fungus, there is most commonly we are seeing pheohypomycosis, hylohypomycosis, mycetoma, that are thing we are seeing. Pheohypomycosis, there is melanin producing organism, pigmented. Hylohypomycosis is non-pigmented. Then what all investigation we will send. As per guideline, we went for bacterial, fungal, TB, bacterial we went sent for gram stain, aerobic, anaerobic culture. TB we went for Jeton, CBNAT, TB culture, fungal, fungal culture, even histopath we went. Other causes non-infective, rheumatoid factor already positive in our patients. We went for ANA and Onca. We went for keywords, we get it for great news. There is pigmented septate hyphae in keywords we get it, but there is organism is not clear whether which one is. Then we went for histopath report. Histopath report shows GMS and Fontana Mason strains. Both are have some hyphae and pseudo hyphae. There is mixed pattern we have started. But melanin producing organism. There is we went for diagnosis like the way possibility of pseudo hypomycosis. That same time culture shows sterile pigmented hyphae, no fruiting bodies, but the organism is not clear, even no growth, clear-cut growth we got it. Then we went for PCR, then we sent the sample to AIMS Bhubaneswar through sir. We are waiting for a report. It will be next week, probably he will get it like the way he told. The approach of fungal pathogen, whether we check for yeast or mold. Yeast means native Cryptococcus and Candida we are getting. Mold means we need to get for Rhizobius micor and Rhizomicor. These are all organisms possible. Endomopteral, Conidiopolis, Basidiopolus, these are all organisms possible. Septate hyphae, we have Chylene fungi or Demesis fungi. Demesis fungi means Alternaria, Bipolaris, Exophiala, Acromonium and all. Hyaline fungi, there is dimorphic fungi, Histoplasma crackidemycosis, Paracrackidemycosis, Dermatophytes, Trichophyton, Microspora, and Epidermophyton, this is all the common. Hyaline septate hyphae, there is Aspergillus, Fusarium, and all the rest, most commonly we are seeing. Approach to Demesis fungi, there is whether superficial infection or mycetoma, chromoplastomycosis, pyohypomycosis. These are different diagnoses for our patients. Then mycetoma, there is we need check for white grain or black grain. There is a triad fitting for that one is we need check for. White grain means pseudo Allergia biodia, Acromonium, and Fusarium. These are all organisms more common. Black grain means we need to pay for Madrona, Mycetoma, Exophiala, and Fonsinia. Chromoplastomycosis, there is most commonly Cladosporium, Fonsinia, and Pialospora. Pyohypomycosis, Exophiala, Curvularia, Bipolaris, Alternaria. Sinusitis, same organisms as Alternaria, Bipolaris, and Curvularia. Mycotic also, mycotic keratitis also, there is possibility of Alternaria, Bipolaris, and Curvularia. Other organism, we know keratitis means Fusarium and Aspergillus, there's something possible. Brain abscess, now there is a rising trend in everywhere. Pyohypomycosis, according to our cases, there is multiple spectrum is possible. Even cutaneous infections, subcutaneous infections are possible. Brain abscess even possible. Even endocarditis, everything is possible with pseudohypomycosis. Common species as per already discussed: Alternaria, Bipolaris, Cladophilopora, Cladosporium, Curvularia, Exophiala, Ponsinia. These are all species most commonly we are seeing. Most common presentation, whether cutaneous or subcutaneous lesions, it should be ulcerated globular swelling like the lesions. We had pigmented fungi. There is pyohypomycosis and hyalohypomycosis. These are all different seasons. Pigmented because of melanin. This will be picked up by Fontana Mason strain. Our case also is the same. Not based on loading those endocarditis supposed to be involved, then we in case for combination therapy. But ideally, source control is predominantly important than antifungal therapy. We need to control for source mainly we need to do. The take home message from our cases is pyohypomycosis. It's uncommon, but we are misdiagnosis with fungal. Chronic history patients we need to consider pyohypomycosis. Treatment based on that, whether localized or disseminated. Immune status, that is based on that. We even many studies disseminated we will use for combination therapy. There is still we are lacking in treatment part in this all thing patients. This all thing is with that I will conclude my session. Thank you.
Santana, you can stop sharing the screen. So if there are any queries, yeah, I think there are no queries. So, sir, what was the final diagnosis? Dr. Santanam, final diagnosis?
The arrived diagnosis of PO hypomycosis, but species we not identified because of culture inconclusive. When we went for PCR with Vinay sir, Boni sir, we sent sample. It's probably next week we will get the results.
So this was the case of subcutaneous PO hypomycosis, species unknown. So, Sir Deepak sir, can we go to the next case? Do you have any questions to be answered? Sir Vinay sir, you want to ask me questions with dyslexic? So let's move on to the next one then. What do you say?
Our next speaker is Dr. Nisrak Shah. And Nisrak Shah is FNB ID fellow at Pindi Hinduja Hospital, Mumbai. And the area of interest for his is TB, HIV, invasive fungal infection, and transplant related infections, as well as gram-negative infections, parasitic infections, travel medicine, and bone and joint infections. And he has done his MBBS from Allen Medical College, Bhopal, and MD in General Medicine from the Medical College, Indore. So he is going to present the next case. Over to you, Dr. Nisran.
Thank you. Thank you, sir, for the introduction. I'll start sharing the screen and
Yes.
the screen visible.
Yes.
Okay. Okay. So today's case is not something very unusual. It is the kind of case we see. I mean, being in the Department of Infectious Diseases, we see on regular basis, especially if we are working closely with onco unit. But I chose this. I chose this case because we had many, diagnostic and therapeutic challenges with this case. And as you know, the theme of this fungal disease awareness week is think fungus. So we have always to keep fungal infections in mind, and fungal infections always pose therapeutic as well as diagnostic challenges. So I'll just start my case. Sorry. So I'm presenting this case of a 9-year-old girl hailing from Kolhapur, Maharashtra, who started spiking fever with chills of in April 2022, which was associated with malaise and fatigue. And she received some intramuscular injection in the left gluteal region in the village for ongoing fever and body ache. And because of ongoing fever, someone advised to get complete blood count done, which was suggestive of pancytopenia. On 26th of April, she underwent bone marrow biopsy, which was suggestive of AML. Now, in the local hospital, she received, she was started on 7+3 induction chemotherapy regimen for AML containing daunorubicin and cetrabine. And simultaneously, she also received cefotaxime as well as voriconazole for antifungal prophylaxis probably. On 2nd of May, she had epistaxis and the relatives brought her to Hinduja Hospital. Now, if we go through the timeline of events, so day +4 post chemo, she was started empirically on meropenem and teicoplanin in view of ongoing fever, and we changed to posaconazole for mold prophylaxis. Baseline chest X-ray was within normal limits, but we do not have any baseline CT scan to go ahead with. All the cultures sent on admission was sterile. Because of ongoing fever, we did the CT chest, abdomen, and pelvis on day +8, which was looking like this. So there is a small nodular enhancing lesion of around 1 centimeter with surrounding GGOs in the posterior basal segment of left lower lung, which from which we started suspecting fungal etiology. If we go ahead with the timeline, so day +14, she developed these rashes all over the abdomen and chest, but sparing palms and soles. And it was associated with some upper respiratory tract symptoms. So our major DDs were measles, rubella, Epstein-Barr virus, maybe COVID, or some other viral examples. So we investigated for these, and so rubella IgM, measles PCR, Epstein-Barr virus IgM, even tropical fever panel, and upper respiratory biofire all were negative. And at this time, posaconazole trough level was 0.6, which was below even prophylactic range. On day +17, because of ongoing fever, we again went ahead with imaging, and this was the imaging. So in the chest, the lesion which was previously there in the left lower lobe, it had increased in size from around 1 centimeter to 3 by 1.5 centimeter with central area of cavitation. And there was a new lesion in the left, it was a collection in the left gluteus maximus with peripheral enhancement. At this time, because posaconazole was ongoing, but the levels were subtherapeutic, and we increased the dose of posa for sure, but simultaneously we started liposomal amphotericin B also, and biopsy or surgery was not possible because of severe neutropenia and thrombocytopenia. Now day 21, because we did not have any tissue diagnosis, and we are always desperate to get tissue diagnosis for any suspected infection as well, especially when it is fungal etiology. So we did the CT paranasal sinuses, which also was showing soft tissue within all left-sided paranasal sinuses, and there were erosions, bony erosions involving left middle and inferior turbinates, as well as uncinate process, which again made us a suspicion of fungal etiology more. On day +23, ENT surgeons got ready and performed FES, but the histopathology of this FES tissue was showing chronic allergic fungal sinusitis. But fortunately, by this time, serum posa trough level reached to therapeutic range. Even I would say supratherapeutic range was 3.5. Now this is just a fever chart. So she got admitted, and so this is the first day. So like this, she was spiking to the glory despite broad spectrum antibiotics, despite posaconazole, and despite liposomal amphotericin B. Now, if we have a look at the investigations broadly, so PCT when she got admitted, so procalcitonin was 15, which favored bacterial etiology and justified our use of broad spectrum antibiotics. After that, the PCT came down to around 1.2 and was hovering around that range only. CRP was up and down. Beta-glucan consecutively was negative. And serum Aspergillus galactomannan, which made more sense performing in this patient because she was neutropenic, was also negative. This is a crude chart to show that she was persistently neutropenic even after day +43 of induction chemotherapy regimen. Although total leukocyte counts had increased to around 1900, but total neutrophils were still below 500. If we summarize the case, so we are dealing with a 9-year-old girl who was diagnosed with AML and received induction chemotherapy and received voriconazole as antifungal prophylaxis. She has ongoing fever despite broad spectrum antibacterial agents and prophylactic posaconazole. She developed the viral exanthem in the interim, which was denoted to be the cause of fever. Chest CT scan was suggestive of query invasive fungal infection, and serial imaging showed increase in the extent of the lesion and a new focus in the pelvic area. And even paranasal sinuses were showing fungal etiology. Now, posaconazole trough level, which was initially found to be low, we reloaded the patient with posaconazole and liposomal amphotericin B was commenced. But any major surgical intervention was not possible because of severe thrombocytopenia mainly. And under platelet and FFP cover, FAS was performed, and histopath turned out to be allergic fungal sinusitis rather than invasive fungal sinusitis. And ultimately, the posaconazole achieved therapeutic plasma level, and amphotericin B was ongoing, but simultaneously fever and persistent neutropenia were also there. Now on 30th May, which was day plus 31, we had to stop amphotericin B because of refractory hypokalemia, but fever was ongoing. Now on 1st of June, because of ongoing fever, we performed PET-CT. So what is this showing? There were just two areas of high-grade metabolic activity. The one area was the lung lesion, and the other area was the pelvic lesion, the left gluteal region. So there was peripherally enhancing thick-walled collection in the left gluteus maximus with central area of photopenia, and the similar findings in the lung, the left lower lobe lesion with central photopenic area. Now, fortunately, under platelet cover, the surgeon agreed to perform IND of the gluteal abscess. This was the calcofluor stain. She was showing broad aseptate fungal hyphae. Histopath was showing extensive infarction of skeletal muscles, extensive fungal invasion of these skeletal muscles, and morphology was resembling zygomycota species. And culture grew Lichthemia columifera, which grew within 2 days of inoculation, despite the patient being on supratherapeutic level of posaconazole and liposomal amphotericin B. Now on day 36, I mean 3rd June, which is day 35, IND was performed, and the next day onwards, fever spikes started coming down. And we could definitely start amphotericin B after this. Now day plus 40, we could perform biopsy of this lung lesion also. And we had similar findings on histopath examination. The culture grew the same species, Lichthymia corymifera, with the same MICs. And at this time, again, the POSA and the LAM were continued, and we advised definitely for source control, which is either lobectomy or resection of the lesion, but could not be performed because of severe neutropenia and thrombocytopenia, because it was a major surgical procedure. Unfortunately, by the end of this month, she had relapse of AML and was discharged on palliative care on oral posaconazole. So what are the take-home messages from this case? So invasive fungal infections are always on our DDs when we are dealing with hematological malignancies, especially AML rather than ALL. And prophylactic agents, prophylactic antifungals, which we are starting, should always cover mucorales, because voriconazole, which was started, so voriconazole in fact increases the risk of mucormycosis, although it is still used to give as an antifungal agent while during chemotherapy with this patient. Histopathological diagnosis of radiologically suspicious lesion is very essential. And therapeutic drug monitoring, although it is altogether a different topic, but as we saw that in this patient, the first trough level was low, and after that we reloaded the patient with posaconazole and we increased the level. So TDM of even therapeutic and as well as prophylactic dose of antifungals is very important. And mucormycosis, especially when it is extensively involving multiple organs, so surgical multidisciplinary approach is essential. And it is not talked much about, but we should go for baseline CT scan of at least chest in patients with AML before starting chemotherapy. That's it. That was my case.
Thank you, Dr. Nisar. It was a wonderful case. And in all the AML cases, do you recommend, what is the prophylactic agent? Do you recommend posaconazole?
So we start posaconazole, especially in hematologic malignancies, but particularly AML, because they are especially at risk of mucor as well as invasive pulmonary aspergillosis. So we always start posaconazole for these patients. Yeah.
I think there's one question. What's the criteria to start empirical antifungal in immunocompromised? And does the days of neutropenia, must it be severe or prolonged more than 10 days if you're considering antifungal prophylaxis?
So in patients with AML and with other neutropenic, other agents which are going to cause profound neutropenia, especially with therapy like citrabine and daunorubicin, which are going to cause neutropenia, which is going to last. After you give citrabine and daunorubicin, the neutropenia, usually the expected duration is around 2 weeks to 3 weeks. So in these patients, we start empirically. Although in other malignancies like CLL and CML, we do not start empiric antifungals. But in AML and ALL, which are at high risk of profound neutropenia, we start them empirically even before starting chemo. So by the time the patient goes into neutropenia, the patient has already achieved prophylactic levels in the plasma levels. So we are at the safe hand.
So what do you think could be the source? That initial IM injections, you're suspecting that is a site which had lit up so much?
Not sure. That's why I highlighted it in the first slide that was IM injection. But definitely the first CT which we performed was not showing any marked lesion in the left gluteal area. But in the subsequent scans, it was showing quite a huge abscess, and it lighted like ring of fire in the PET scan. And that's it. Yeah.
Okay. Are there any more questions? Anyone would like to ask any question? Sir, any questions, sir? Or any comments on the case, sir?
I think these are quite rare cases, and so more questions are not coming because of the rarity of the cases. But it is very learning for us, all of us.
Thank you, sir. Thank you, sir.
So, okay, thank you. Thank you, Dr. Nisar. And so we'll now move to the next case presentation. So next we have, sir, over to you, sir.
Yeah. The next case will be discussed by Dr. Asna Gandhi, and she is a FNB ID fellow in I think in the Jupiter Hospital, Pune. And area of interest for her is TB, HIV, invasive fungal infection, and transplant related infection. And she did his MD from Topiwala National Medical College and BYL Nair Hospital, Mumbai, and MD from Jawaharlal Nehru College, KL University, Belgaum. Over to you, Dr. Asna.
Just 1 second, I'll just share my slides visible. Hello.
Yeah, slides are visible. Can you put it on screen? Yeah, slide. Yes.
Thank you. I'll just start. So I'll start with the case directly. This is a case of a 38-year-old male, a poultry farmer, no habits, recently diagnosed diabetic and hypertensive. He was admitted on the 12th of January at our hospital with fever, cough with expectoration, and bloody sputum. He recovered with symptomatic treatment. At this point, ID reference was not taken, and they treated him, and he had recovered and gone back home. Just a second. Then he was admitted again a few days later on the 24th of Jan with cough, fever, breathlessness. An HRCT was done which showed multiple small peribronchovascular nodules in both the lower and the right middle lobe, some subpleural nodules in the bilateral upper lobes. A galactomannan was done which was 0.7, slightly positive. BDG was 160. So with the suspicion of probable IPA, this patient was started on voriconazole. Again, he was discharged on the 30th of Jan and readmitted on the 31st of Jan with multiple episodes of hemoptysis, persistent cough, breathlessness, and fever. So this is his HRCT, a repeat HRCT was done. When we examined him, there were bilateral Krebs scattered bronchi, and a repeat HRCT which showed a large nodule in the left lower zone. Basically, it was a nodule with surrounding ground glassing. So we thought maybe it could have been just the aspirated blood because of the hemoptysis. It could have been TB or obviously aspergillosis, which even the biomarkers were positive. So it seemed like one of these possibilities. So we did a sputum analysis for him, and this, with no surprise, showed us aspergillosis. There were narrow, acute angled septate fungal elements. This is the KOH calcofluor, and even the ZN and the gram stain actually showed us these structures. And Aspergillus fumigatus also grew on culture. So this patient, in spite of being on voriconazole, treated properly, diagnosed properly, he still continued to have a lot of hemoptysis and cough. So bronchoscopy was performed for him. Bronchoscopy revealed extensive airway involvement, multiple hyperemic areas, as you can see in these images, with pseudomembranes. This was suggestive of airway invasive aspergillosis, and the infiltrate on HRCT was probably aspirated blood and not actually pulmonary aspergillosis. So these are the images. If you can see the bronchoscopic images, they are very necrotic, full of pseudomembrane, and there are a lot of congested areas as well. So we took samples from the pseudomembrane in the airways, which also showed the same results. So VORI was continued, but what additional thing that we did was we added nebulized liposomal amphoby, which actually could go into the airways directly and give us some local concentration over there. And after all of this, the patient recovered well and was discharged. So this is just a small case which highlights something which is not so common, which is airway invasive aspergillosis. What we usually end up seeing is a lot of pulmonary aspergillosis, and this may be neglected sometimes because the CTs may be normal, and you may have to do a bronchoscopy to actually diagnose the same. In this case, we did get the diagnosis on sputum, but sometimes it may be elusive. So a word about nebulized liposomal amphoby. So liposomal amphoby in the nebulized format is basically approved for prophylaxis for reducing the incidence of IPA. So it's approved in lung transplant patients and in neutropenia. So these are some papers which describe the same, but the studies are only for prophylaxis and not for treatment. Again, there are no clear guidelines on aerosolization. When we actually wanted to give our patients nebulized amphoby, difficult to find the doses, difficult to find the right way to give it. Again, no comparative studies which compare aerosolized forms and systemically administered azole. So what we did in this case was gave systemic azole and gave nebulized amphotericin B along with it. We also do have some cases where we have used this for mucor as well with good results. Again, there are no other guidelines on other agents. So no guidelines on echinocandins, no guidelines on azoles, whether they can be nebulized. So lots of problems in this case, but definitely it can be tried on a case-to-case basis, and it does give you good results. So the take-home messages from my case are that airway invasive aspergillosis is relatively rare. And in this case, the patient was not immunocompromised, but he was a poultry farmer. He said that he used to drive a chicken cart every day with a lot of chicken in his, he used to get exposed to a lot of this, the feathers of the chickens and all. So we assumed that probably was an occupational exposure of a lot of aspergillosis. He had inhaled a lot of it. So maybe that was the reason he got such an extensive disease. So approach to treatment may be modified, and nebulization for liposomal amphob can be used to provide high concentration in the air.
I think a very excellent case, Dr. Asna. I just want to ask one thing. What dose you have used in this patient?
So we gave 12.5 mg of nebulized amphob. It's diluted in 1 to 2 ml NS. There are honestly speaking, so no proper guidelines on how exactly to give it. So similar to the way you give colistin nebs in the ICU, we give amphob, and it has to be liposomal amphob. Amphodeoxycholate, it seems, has a lot of issues with bronchospasm. So ideally avoid those things and give liposomal. Liposomal is the one which is preferred. So we tried it in a few cases with mucor as well, with good results. So I don't know whether it was the systemic thing which gave us the good result, because we've always tried it in combination, never alone. But this patient definitely improved after the nebulization, and before that he was not all right.
I think it is very important point, and further larger study can be done to find the result
Definitely,
of this
yes.
inhalation liposomal B. Yeah, thank you.
Thank you so much.
There is one question in the chat box. What is the difference between airway invasive aspergillosis versus usual pulmonary aspergillosis?
So just the site. So what you call tracheobronchitis, that's your airway invasive aspergillosis, and pulmonary is the one which will give you a lung infiltrate. Yes, we first thought it was a pulmonary IPA, but in the end, we actually realized that it was actually aspirated blood, because eventually the patient's HRCT did improve. And he had such an extensive disease when we did a bronchoscopy. It was definitely primarily the airways were involved. Even if that lesion was aspergillosis, it was definitely not the cause of all his problems. He had so much hemolysis, a bad bronchospasm we had first seen him. It was definitely an airway disease. So pulmonary and tracheobronchitis or airway invasive aspergillosis, whatever you call it.
Yes. So that is what airway invasive aspergillosis may not have your typical like chest findings and say radiological, and it may be the initial form, especially non-usual risk factors, non-neutropenic patients. Yes. Thank you, Dr. Ashna, for such a wonderful case. I mean, it's a very common case, but yeah,
it has different ways of treating it and approaching it. So that's why I wanted to present. Yeah. Thank you so much. Thank you for the opportunity. Thank you.
Thank you. So now we'll move on to the last but not the least presentation. So could you stop sharing? Yeah. What do you, sir?
Our next speaker is Dr. V. Teja, and Dr. V. Teja is a resident in the infectious disease at School of Tropical Medicine, and she did a MD from the SMC Vijayawada and MD from NRI Medical College Guntur, and she received first oral presentation first award in the Epicon 2019 and HepCon 2023 and ICON 2019, and third position in the poster presentation in STMID 2023 and SITS Conquest 2023. Means she received lot of awards in the publication, and she has multiple publication in Indian Journal. Over to you, Dr. Teja.
Yes, Dr. Teja, can start sharing the screen now?
Yes. Yeah. 1 second. Can you see my slides?
Yeah, I can see your slides. Maybe you can switch off the video. I think the net connection is not quite good. So Video you can turn off.
Acha, okay, okay.
Yeah, and you can continue. Yes.
Okay, I'll do that. It's 1 minute. Are my slides visible?
Yes, yes, please.
Yes. Okay. I'll carry on with the case. So moving to the patient particulars, it is a 50-year male patient living in Kolkata, normotensive, non-diabetic. My slides are not moving.
Okay. Can you reshare? Stop sharing and
Yeah.
reshare the.
Yeah. Are they moving now? Yes. So moving on to the chief complaint, the patient has chief complaint of cough since 1 month and chief complaint of SOB since 1 month and fever since 10 days. So cough was insidious onset, gradually progressive, productive with moderate amount, white to yellowish color, non-foul smelling, associated with streaky hemoptysis, intermittent fever, which was not relieved on medication. Shortness of breath was insidious in onset, grade 2 to 3. There was no orthopnea or PND and not associated with any chest pain. So there is a low-grade intermittent fever, which was on and off in pattern with occasional night sweats, not associated with chills. There was significant weight loss of about 10 kg in last 1 month. So all these, as we all know, the 4S symptoms of the TB could be seen here. And he was recently diagnosed as PLHIV with CD4 count of 97. He is ART naive. He had no past history of tuberculosis. He had a contact history of PTB from his brother in childhood. No history of recent travel. He had admitted in hospital on June 2020 for COVID-19 pneumonia. He is not a non-diabetic, hypertensive, CKD, CAD or CLD. So on clinical examination, patient was alert, conscious and cooperative. GCS was 15 by 15. There is average build with pure nutrition. Pallor was present. There was no cyanosis, jaundice, clubbing or lymphadenopathy. So the vitals were normal except for the SpO2, which was 92% on room air. And so cardiovascular system was normal. Respiratory system, we could see bilateral infrascapular area and infraaxillary area. Coarse crepitations were present. And per abdomen and CNS was normal. So possibilities, there is a 54-year recently diagnosed PLHIV with CD4 count of 97 with fever, cough, SOB and weight loss. All the 4 symptoms of TB were present with bilateral crepitation. The most common possibility we kept it could be a case of non-resolving bacterial pneumonia or atypical pneumonia, tuberculosis, PCP pneumonia, NTM, nocardiosis, and invasive fungal infection. So on evaluation, the complete blood hemogram was showing only mild microcytic hypochromic anemia with anisocytosis. Liver function test and blood sugar was normal. Inflammatory markers were normal. In serology, as we all know, HIV is reactive and HBsAg and anti-HCV were non-reactive. As he is a known patient of HIV with CD4 count of 96, we performed the toxo IgG, which was negative. VDRL was negative. Only thing to remember here is the CRAG is also non-reactive. So moving on, the next chest X-ray. In the chest X-ray, as you could see, there is a lesion over the right side with the right mid-lobe. We can see a consolidatory type of lesion. So it could be due to tuberculosis or NTM, nocardia, all the things we have discussed previously. So actually this case till here was not with us. It was with the tropical medicine and after this it was referred to us. So they have actually started empirical ATD and referred the case to us. They have done the sputum examination. Gram stain culture showed no growth. AFB was not found. Modified AFB for nocardia was negative. Fungal stain and culture was done from the sputum, which was negative. Sputum CBNAT was negative. Sputum MGIT culture was also done, which showed no growth. So urine was done, which was normal. Stool was also normal. So the HRCT shows the same lesion, which is significant involving the mid and the lower zone of the right side. So we went ahead with the to get the samples, we did the CT guided FNAC. From the cytology, we have plenty of macrophage infiltration with multiple budding yeast cells. As you could see here, we had multiple budding yeast cells, which were approximate 8 microns of size, and clusters were present. Here you could see one with encapsulated budding yeast cells. Here you could see one more. So we have multiple. Gram stain culture sensitivity FB was negative, CB-net was negative, MGIT culture was negative. And so KOH stain, in this KOH stain also you could see a budding yeast cell with surrounded capsule, and one more also you could see 2 budding yeast cells surrounded with a capsule. And next day the mycology ma'am called, she showed, and other than the budding yeast cells, we could also see a hyphae. Fungal hyphae was also present in the KOH amount. And budding yeast cells, other than the previously seen budding yeast cells, there were some other budding yeast cells which have to be identified. So then the fungal culture was done. The fungal culture which was done on SDA showed fluffy white colonies. This is the obverse view and this is the reverse view. So on identification, they have done fungal blood culture also, blood agar culture, which was showing the growth of fungal colonies. As you could see here, there is multiple growth. So it was identified next day as yeast form of one of the most uncommon fungus, that is blastomyces. As you could see, there is a budding yeast which was attached here, which is of 8 microns in size in a figure of 8 pattern, which is most classical for blastomyces. So this was the LPCB, where we could see the conidial form or the mold form, the microconidia, which are fiery form in nature. Multiple conidial form or mold form was present. So this was identified to be a blastomyces. And the previous one, which we have seen here, this is actually the cryptococcus. So this patient is now having 2 fungal infection, that is invasive cryptococcus, that is pulmonary cryptococcus, as well as pulmonary blastomyces with a high load of blastomyces. So we thought the serum CRAG in this patient was negative, as previously mentioned. So we see if there is any dissemination is present, as both could cause dissemination. So we sought for CECT abdomen and MRI brain. There was no lesions in MRI brain or CECT abdomen. So we proceeded with the diagnosis. The final diagnosis is a PLHIV, WHO stage 4 disease with ART name with CD4 count of 97 and isolated pulmonary invasive fungal co-infection, that is with blastomyces and cryptococcosis. So how we would proceed with the treatment? We managed as injection amphotericin B deoxycholate, which was given 1 mg per kg for 14 days. As it is a co-infection with cryptococcal load was low, as mentioned by the mycology team, and blastomyces load was more. So we proceeded with the combination of itraconazole of 200 mg TDS for 3 days, followed by 200 mg BD for 12 months was planned, and tablet cotrimoxazole as the CD4 count was 97. And as you know, because of the iris, the TLD was started after the 2 weeks of abort treatment with amphotericin B. TLD, itraconazole and cotrimoxazole were continued. And TLD is the ART regimen, that is tenofovir, lamivudine and dolutegravir. So after follow-up, 2 weeks post amphotericin B, you could see the lung lesion, which was previously of this size, has been reduced post amphotericin B. So the patient actually responded to the therapy of amphotericin B, the induction phase. She is yet to come after the 3 to 4 months follow-up itraconazole. So we don't have the follow-up X-ray with itraconazole. So this case is special because in a PLHIV, we know multiple co-infections can be seen, that is bacterial infection with parasitic infection, 1 fungal infection. But this is unique case having both fungal infection in the pulmonary area only without any dissemination. And most importantly, the serum CRAG, which is most which has most sensitivity and specificity, was negative in this patient. And only 1 article I could find, that too not of blastomyces. I found there is a cryptococcal fungemia and probable histoplasmosis co-infection. There are multiple series or case reports, 12 to 20 cases having co-infection of cryptococcal fungemia and histoplasmosis. They were treated with multiple regimens like amphotericin B, flucytosine, fluconazole. Some patients were treated like us, amphotericin B, itraconazole. Some even didn't, some immunocompetent also had co-infection, not only the HIV, immunocompetent also had the co-infection. They didn't even receive the treatment. So this you can see in BMC infectious diseases. So this is a publication only. Blastomyces I couldn't get, only cryptococcal and probable histoplasmosis was in co-infection was seen. So thank you.
Thank you, Dr. Teja, for a wonderful presentation. As we all know, HIV is a Pandora's box. So there can be you can look for multiple infections and you will find them. So there is a popular Occam's razor and Hickham's dictum. So which does not, so Occam's razor does not hold good for HIV. So I just have few questions. So like was CSF done in this patient, or I mean, because he didn't have any symptoms, or just because he had some pulmonary cryptococcus positive?
Yeah, we planned for the CSF in this patient, but the cryptococcal load was very less, and as MRI was not showing any lesion, and the patient doesn't complain of headache or anything, so we didn't proceed with doing the CSF. CSF was not done in this patient.
Yeah. So there's a question: negative serum responsible? Yeah, like yesterday we had discussed in the yesterday's webinar. Cryptococcal life cycle, you see, cryptococcal is basically a lung, first primary disease of the lung. So maybe this is in the early stages. So maybe that is the reason.
Yes, it is in the early stages. The load may be less. So the crack which we get positivity should be a disseminated case. Then only we can get the serum crack positive.
Yes. So Vinay, sir, please ask the question, sir. You can unmute yourself and ask, sir.
Dr. Teja, interesting case.
Yes, sir. Thank you.
But you know, I actually have a very basic question. Blastomyces is considered as an endemic mycosis, and blastomyces is not endemic in India. This patient, this patient gave history of travel abroad to USA or somewhere.
No, sir. No. She is very low socioeconomic status. She didn't even travel outside from Kolkata. He said he was residing in Kolkata, that too of the same area of our hospital. We planned to send NGS and PCR, but the patient was not affordable. Actually, Tata Medical Center does the NGS. We thought to send the sample, but the patient was not willing for the same.
No, the thing is, this isolate, if your mycology team is still holding this isolate, then they can send it across to me. Okay, but you know, very frankly speaking, this unless it is sequence proven, this
yes, sir. We also thought that culture proven. Yes, sir. We contacted with the PGI team. Yes, sir. Yes, sir. When we got the blastomyces, we were also shocked. We contacted the PGI team. We shared all the photos with the mycology team there. They also said it could be a suspect. Please send for NGS and PCR, but the patient was not willing for the same.
No, the isolate. See, another thing is because this patient was HIV positive. Did you and blasto closely mimics emergomyces? Did you think of emergomyces?
So we did think of other possibilities other than blastomycosis. So that's why we wanted a molecular identification rather than a phenotypic identification. So it was molecular identification is not done at our site. So we contacted Tata. They actually said NGS will be doing for 3,000 to 5,000, but the patient was not willing to pay.
No, you need not
if it is a free.
No, see, this NGS thing is not required for once you have the isolate. Okay, so you can send it over to either me or to PGI. We'll do the identification free for you. Okay, you don't have. You just have to pay for the 50 rupees. Yeah, For the
Yeah,
postal
sure,
fees,
sir.
other than that,
Yeah,
you don't
sure.
have to do anything.
Okay, sir. I'll talk with the mycology ma'am and I will let you know, sir.
Yes, yes,
I'll
yes.
send actually the sample, this one, and there is also one more case. I think they have identified 2 cases of blastomyces in our center. So both, if they are stored in mycology lab, if it is possible, I will let you know, sir. We can send both the samples for identification.
Yes.
So for
Yes.
sending, won't there be an issue of this one BSL? Like how do they send the samples?
Akshatha, in BTDC, we actually send it for PGI for histo. Once we had sent it for
other samples, I agree.
So,
I agree. Other samples, I agree. This blasto, I'm specifically asking because it's one of the BSL-3 organism which has an implication with bioterrorism. So you will need to be very careful, sir. Sir, how can they go about
no,
this?
they will actually, for sending, they will take a format from us. Something, there is a format of the government to send like these samples.
Okay.
So before BSL-3 samples, I think signature is needed from our HOD and all. We can send actually the sample.
One more issue I had, like, why was amphotericin B given in this patient? As I can see, maybe it is not a very severe form, just a pulmonary infection where the patient was not having
initially, yes. But the patient was very sick and she was having continuous sputum expectoration with hemoptysis increasing. So we thought we will be giving amphotericin B before itraconazole. It is actually if we consider the case, it is a mild to moderate. It comes under mild to moderate. So itraconazole would have been sufficient. But we have given amphotericin B initially because the patient was very sick and we thought we could hit early. So we have given amphotericin B, and actually only cryptococcal first we thought. The blastomyces part was laterly informed. We have already started amphotericin B when we have seen some yeast-like thing and there is an encapsulated budding yeast. So we initially thought then after 2 days, the blastomyces part was actually revealed. So we continued with the amphotericin.
Was not considered because like even in initially it was
cryptococcus. Initially cryptococcal we thought
for that also.
Ampho plus fluconazole, yes. In HIV, if we follow WHO guidelines, ampho and flucytosine is actually preferred for the induction phase.
CNS.
So
that is only for CNS,
but
cryptococcus is there is no combination.
Before that, we didn't do MRI. So before starting ampho, we didn't do any MRI, CT scan, or we didn't do any CSF. So we don't know whether it is disseminated or it is pulmonary. So we initially thought if it could be disseminated, we will start with the amphotericin B and flucytosine. But flucytosine we didn't start. We started amphotericin B, and for next day it was actually informed that it is also having blastomyces. So we thought plain amphotericin B would be enough.
Yeah, I think there's a question to Vinay says which fungus resembles. Sir was mentioning it's emergomycosis. Sir, would you like to add a comment on this, sir?
Yeah, so emergomycosis is the name of the disease. Emergomyces is the organism, and there are several organisms in this group. And this was first described in HIV patients by Nilesh Govender and group from South Africa. And culture-wise, phenotypically, it actually mimics blastomyces. And from India, there have been, and the speciality of this bug is that it affects people with HIV, and usually there is dissemination to skin. Skin and soft tissue is involved in this bug. And in India, emergomyces has been reported mainly from Delhi by Dr. Malini Kapoor probably she is from Safdarjung Medical College. And that was again confirmed at PGI Chandigarh following sequencing of the isolate. So treatment wise, again, if the patient is very sick, you start with amphotericin B, and once the patient is stable, you can shift the patient to oral itraconazole. It's the same like all other dimorphic fungi.
Thank you, sir. Okay, so if there are no other questions, we can end it. So again, I heartful gratitude to Deepak sir and Dr. Vinay sir for joining us and making the session fruitful. So if you have any other queries, you can leave it in the chat box, or maybe we can have. So today's is not the end of the webinars. So next we have it on 22nd. It's the third webinar, and there are more interesting fungal cases which will be presented, and followed by the last webinar on 25th, where we are going to discuss on anti-fungal stewardship, the need of the hour by Dr. Rakesh Singh from JIPMER. And just reminder for ASPICON, so we have our conference ASPICON, which is 29 to 1st of October, and this time it is in hybrid mode. And for those participants who are going to join us online, we have a quiz for the virtual participants as well. So I request all of you to join us in this. So with that, I think we can end this. Thank you. So if you have any queries, you can leave it on any of the social media. I can address it. And the recording is available on the YouTube channel. So in case anyone has missed it, can or any part of the session you want to have a look again, you can check out my YouTube channel. So again, I would like to thank all the participants for joining this webinar and making it a success. I also will be sharing the feedback form. I request all of you to fill it so that I get a feedback on what you want, what you like, what is not like, and I can take the necessary action. Thank you again. Good night.